And without further ado, Caring for Adults with Acute Leukemia in North Carolina, updates for 2023. And we do have a bio which we'll share, and if you want to look back over that later, you can as well, but we've decided to pick out the top 5 for Dr. Richardson. He is an assistant professor with the University of North Carolina and a member of the Lineberger Comprehensive Cancer Center. He cares primarily for patients with acute leukemia, but also attends to patients with myelodysplastic syndromes. His research interests include patient preferences and values, patient-centered outcomes, geriatric oncology, and shared decision-making. The goal of his research career is to improve the quality of care and outcomes of patients with cancer. And number 1, Dr. Richardson leads a research team that develops novel strategies to improve patient-centered care. Dr. Richardson, welcome.
Thanks so much, Tim. It's awesome to be here. I really appreciate it.
Thank you. We are very excited to have you here. What, outside of your professional realm, what's one thing we should know about you?
Well, you should probably know that I have 3 kids. My wife and I have been here in North Carolina for about 6 years or so. We came from Ohio, so we're loving the weather now. Kids love to be outside. We're greatly enjoying being here at UNC in North Carolina.
Well, we love having you here. So thank you so much. I'll mention poll everywhere, and we usually do a softball at the beginning. What one word comes to mind when you hear the words acute leukemia? So that may be, sometimes it's hard to pick just one word, but for the word cloud, try to come up with one. I'm going to flash up our disclosures while everyone's thinking about that. Got a few of those. And here we go. So we've already got one. This one's moderated, so I'll be looking for those, and we'll see that word cloud start to fill up in the next minute or so here. So again, go ahead and put what one word comes to mind when you hear the words acute leukemia. Yeah, I like that one, yikes. All right, we'll take maybe 10 more seconds. Definitely having some that are showing up multiple times. All right, here, we've got a few more that just came in. Dr. Richardson, is this what you would expect to hear people say?
Yeah, I think that, I do this every day. And I actually don't, I still have these same thoughts running through my head as I'm going to see my new patients with leukemia. So, scary, risk, worry, serious, yikes, treatment, and kind of thinking through everything that's flowing through their head as I go into the room to see them. So yeah, this is, it really hits home for sure.
All right. And without further ado, we'll go ahead and turn it over to you. Caring for older adults with acute leukemia in North Carolina, updates for 2023.
Well, thanks, Tim. And it is really my privilege to be here today. I'm really thankful for the opportunity to speak. It's, I'd be lying if I didn't say that I love caring for patients with older patients with acute leukemia. It's something that I'm really passionate about and really thankful for. And so I'll share just a little bit as we get started about kind of why that is. Coming into medicine, my mom was diagnosed with breast cancer early on, and so I knew I wanted to probably be in oncology. And I had a few experiences as a resident and as a in medical training with patients with acute leukemia. And I think all the words that were just shown on the screen are really valuable to think about, just this place where the patient is coming in, their life is going one direction, and all of a sudden it's as if they've been teleported into an entirely different life, and they have all these fears and worries and everything else that's going through their head. And so walking into that room, I really, saw this just tremendous opportunity to care for patients really in their hour of greatest needs and walk through their suffering with them and to care for them right in the midst of all of their darkness. And it was such a rewarding time to do as a medical student and a resident and as fellow. And now I just see that as such a great, both an opportunity and also, really a sacred responsibility to care for patients in that way. So today we'll talk a little bit about updates for 2023. We'll talk about some paradigm shifts that have happened in acute leukemia in terms of treatment. And then I'm going to highlight a lot throughout this talk some updates for how do we incorporate more of the patient voice into the care of patients with leukemia. So how can we know what matters most to them? And then how can we enhance our shared decision-making for that? So that was a long and extended introduction. So we'll jump to the learning objectives here. So we'll talk about frontline options for older adults with AML based on disease characteristics, frailty, and patient preference. We'll identify 2 recent developments in AML that have moved the field to consider waiting for molecular testing to make treatment decisions. We'll describe treatment options for older adults with Ph-positive ALL. And then we'll talk about the benefits of geriatric assessment for older adults with leukemia. And so I usually start with a few slides to most of my presentation that focus us really on the heart of medicine and what we're really doing with our caring for patients on a day-to-day level. The Institute of Medicine has given out many reports over the years. This one came in 2013 and really highlighted a crisis in cancer care quality. And they said cancer care is often not as patient-centered, accessible, coordinated, or evidence-based as it could be, detrimentally impacting patients. And I think this is really summed up in a quote by Atul Gawande, who says, the vast majority of people have concerns about the care they receive not being in alignment with what matters to them most. And he was talking about oncologists or providers or clinicians, ask patients less than a quarter of the time about their priorities. And 75% of the time, we deliver care outside of their priorities. And here's the kicker here. And the result is suffering. And so when I heard him say this, it really hit kind of a nerve with me as I thought about my mom going through cancer treatment and others going through cancer treatment, and our broader responsibility to bring the patient in front of us to understand what matters most to them so that we can deliver care that is in alignment with their priorities. And so as I talk about patient-centered care a little bit throughout this talk and other things, in an ideal world, this is what it looks like. As all of us go into the room to care for our patients, it should look like this. It should look like us and the patient in the room, and we can focus on what matters most to them. We can spend quality time with them and really understand what's going on with them. But in reality, we have many competing priorities in our life. So we have the priorities of understanding everything about the chemotherapy. We have priorities of understanding everything about their disease biology and trying to figure that out. We're under time constraints from the healthcare system at large and trying to be more efficient. And then, we have all of this other, aspects from thinking through all of the clinical aspects of their care as well. And so many of these very important priorities are competing for the time with the patient in that room. And so we'll talk today about a few tools that have been developed to foster shared decision-making among older adults. And my eye is going to be on patients with acute leukemia because that's who I see predominantly in clinic. However, these tools are really applicable across certainly oncology and across much of medicine as well. All right, so I'll take a step back and we'll talk about acute myeloid leukemia and evolving treatment paradigms. I know that Josh Zeidner has given a previous talk on some of this as well, and we won't go too deep into all the nuances of treatment of AML, but it allows for kind of a nice frame to think about shared decision-making, and then really about kind of as medicine is transforming how best to care for patients. All right, so acute myeloid leukemia, about 21,000 patients are diagnosed in the U.S. each year, and it's really a diagnosis of older adults, so median age of 67 or so. And the treatment paradigms in general fall into a few buckets, and we'll talk about these buckets as we go through. But in general, high-intensity therapy or intensive induction is usually what you would think about of your 7+3 high intensity. You're sending patients in, they're in the hospital for 4 to 6 weeks, inpatient, lots of side effects, et cetera. A second paradigm is more outpatient therapy, and we'll really talk a lot more about this and in introducing novel agents such as venetoclax into the mix here. Certainly we think about clinical trials, and then we think about best supportive care only for those patients that are really too frail at all to receive any chemotherapy. Overall, prognosis is pretty poor for adults, specifically older adults, and I'll talk about that in a second. And then we don't talk about survivorship too much in leukemia because we're so focused on that initial upfront diagnosis and chemotherapy, really as you all highlighted in that word cloud. But side effects are often long-standing and chronic. So over 90% of patients will have long-term side effects, and 30% will have one or more severe side effects. And this is a Kaplan-Meier curve showing kind of the survival of older adults. And so what you can see is each of these curves is really in our decade going forward. So 55 to or 55 to 65, et cetera, et cetera, et cetera. And what you can see is that older patients do substantially worse. And so as patients get older, outcomes are substantially worse for these patients. And so that really makes us beg the question about how do we deliver care that's most in alignment with them. All right, so let's talk about some big paradigm shifts in AML. So this is a slide that came from 2019 that I like a lot. It basically demonstrates that for about 40 years or so, we were using the same chemotherapy. So this is on the left side of this screen. You'll see 3+7. So often we'll call it 3+7 or 7+3. So this is our cytarabine plus anthracycline-based regimens. And this has been our standard of care really since the 1970s or so. And since really 2000 and really 2010s, we've seen a huge paradigm shift and a huge expansion of novel agents in AML. So you can see them listed here. So CPX-351, gemtuzumab, venetoclax, midostaurin, gilteritinib, et cetera. And what we see is this is going to open up a possibility for delivering patient-centered care. And even in the last couple years, and so this is now 2023, even from that slide, we now have multiple additional agents that have been approved. So CC486, which is oral azacitidine, is now approved, ivosidenib plus azacitidine, olutasidenib, and then I even added this one, which was just approved in the last several months, quizartinib, approved for patients with FLT3 mutated AML. And so what we see in AML is this kind of moving forward of more and more treatment options for patients, which is a real, it's real wind in our sails for leukemia docs who've been treating patients really for the last 40 years or so with the same chemotherapy. So let me take a kind of a look back into the patient. So I showed that previous slide of sitting with the patient, and this is really what I think about as we think about making treatment decisions for patients with AML. So patients come in and they've had a bomb drop in their life where their life was going one way, and they've as one patient put it, they've been abducted by the illness. This AML has taken kind of their life, and they're in really devastating shock. They're experiencing uncertainty, difficulty making decisions. You know, I think about some of those words at the beginning: shock, scary, fear, uncertainty, et cetera. All of that patients are experiencing. And it's our responsibility as kind of the treatment team to take all of the clinical features and then think about the potential outcomes to arrive at multiple different treatment options and really pick the thing that is going to be really best for the patient. So how do we begin to do that, and how well are we doing that right now? And you know, going back to the initial slide that I showed on the crisis and cancer care quality, it's been a real challenge to deliver high quality care for patients with AML for many of these factors. So previous studies have shown poor patient-provider concordance on goals and prognosis. Patients frequently report being left out of treatment decision-making or not being informed about treatment options. High rates of prognostic discordance, and we'll touch on this down the road. Low levels of preference elicitation, high rates of patient dissatisfaction with communication and decision-making. And so in general, we're seeing kind of what the IOM said in 2013, really this crisis of cancer care and the big barriers that we have with patient distress, acute decision-making, all of that playing out in patients' experience of treatment decision-making. So we'll talk today a little bit about how we can improve and what we can do. So I'm going to set it up with this case of an older patient with AML, no surprise. And then this is moving into kind of the audience participation, so pay attention to this clinical case, and we'll ask some questions about this patient here in a bit. So let me introduce you to Miss AML. So certainly fictional case, but this is a patient that, you know, I'll see, you know, this paradigm patient often. So 70-year-old woman, comes in with pancytopenia, so low blood counts across the board. She has diabetes, hypertension. She had a bone marrow biopsy done showing AML and a normal karyotype and no targetable mutations on NGS, which is next generation sequencing. We'll talk about that here in a second. And then her AML risk group, based on kind of what I've shown, is intermediate risk. And so how do we think about this patient who's sitting with intermediate risk disease, who is on the older side, so 70 years old with some comorbidities, and how do we think through what kind of paradigm, what kind of intensity of treatment we're going to give them? And so here's kind of how I think through this, and then we'll offer you the opportunity to kind of weigh in as well. So big picture, so you'll see that the arrow at the bottom of the screen here, so intensity of chemotherapy, so the most intense is sitting there on the left side, so high intensity chemotherapy. In the middle is intermediate intensity chemotherapy, and then on the right side is low intensity chemotherapy. So you know, not on this slide is kind of best supportive care only, and I'll hit on that in a second. So what you can see, you know, really with these buckets is that we're going to have very different outcomes, both side effects and then efficacy outcomes, depending on which bucket that we pick to treat patients in. So let's talk about high intensity. So as I said, this is has been the standard for the last 40 years. This is your 7+3. More recently, we've developed other drugs to add on top of 7+3. So these are some of the things that we talked about before. The midostaurin, et cetera. CPX-351 is for patients with myelodysplastic related changes. And this has been our gold standard. In this, we're really trying to get our highest bang for the buck in the acute setting. So high side effects, high time admitted to the hospital. As I said before, about 4 to 6 weeks patients spend in the hospital. And really, we're hoping here to extend survival. And we'll talk about that here in a second on how well we're going to do that. Certainly, we're going to try to increase our bone marrow transplant or stem cell transplant rates, which is kind of our main curative therapy for intermediate risk AML. So then second, intermediate intensity chemotherapy. This is kind of developed since 2018 in the development of venetoclax. So this is our other option that we're often thinking about for patients who may be eligible for higher intensity therapy. So this is our novel therapy. Often we can do this largely outpatient, lower side effects, more days at home. And there's some questions about, does this have the same efficacy as high intensity therapy? And then low intensity, the last one here on the right side. So this is going to be our single agent hypomethylating agent, so azacitidine or decitabine. Overall, very well tolerated. All of this can be done outpatient, but certainly the remission rates are substantially lower than for those in the high intensity and intermediate intensity treated patients. Remission rates for low intensity treated patients are often around 20% or so. And so let's talk about the two major developments that have really changed the treatment paradigm for AML in the last 5 years. So the first one was really the development of this intermediate category and the understanding that there are similar remission rates between high intensity treated patients and intermediate intensity treated patients. And so what we're seeing is that patients treated with azacitidine plus venetoclax or decitabine plus venetoclax have similar remission rates than those treated on high intensity paradigms. So on the 7+3, CPX, et cetera. And this allowed us to think about introducing clinical equipoise. So now we think a lot about, it's not just patients coming in with AML, and so we then just standardly do 7+3. Really, we have some time to think about clinical equipoise and deciding between these two treatment options. The second major development is the development of next-generation sequencing to really help guide our care. So next-generation sequencing is identifying specific mutations that are driving the AML. And many times we have targeted therapies. The paradigm for this is FLT3 mutations, but also IDH1 mutations and others, where we have specific mutations that will actually help determine upfront therapy for patients or guide upfront therapy for patients and make patients eligible for one therapy over the other. And in papers down here, so this Bird et al. Paper from 2020, this rolling paper from 2020 as well, have demonstrated that waiting for next generation sequencing for patients does not affect outcomes for these patients. And so oftentimes we'll have patients come into the hospital, we'll do the bone marrow biopsy, and then we're waiting for next generation sequencing to come back on these patients. And providing supportive care, often transfusions, et cetera. And so what these two movements have done for treatment decision-making in AML has opened up a window where now, instead of having patients present acutely and us wanting to start chemotherapy right away, we now have the opportunity to think a little bit more deeply about their frailty and about what matters most to them. So these are two major treatment paradigm shifts in AML, from treat everybody as fast as we can to really waiting for the next generation sequencing to come back, and then also thinking about doing outpatient chemotherapy with often combination azacitidine plus venetoclax. I'll mention here as well that several papers have come out looking at low intensity chemotherapy versus best supportive care alone. And what we see is that patients who receive low intensity chemotherapy with azacitidine or decitabine as compared to just best supportive care the patients receiving chemotherapy survive longer and actually report better quality of life than those patients who receive best supportive care only. And so often I only reserve best supportive care only for patients who are exceedingly sick and are often, actively dying, because low intensity chemotherapy can often stabilize their disease. Even if we aren't on a curative paradigm, it can also provide quality of life benefits for patients and help them survive longer. All right, so those are the two major shifts in treatment decision-making for patients. And so let's think about our 70-year-old here. So a 70-year-old with AML, again, normal karyotype, intermediate risk disease. We want to know what bucket are you going to put them in? Are you going to do high-intensity chemotherapy? Are you going to do intermediate intensity chemotherapy? Low-intensity chemotherapy, or best supportive care? So here's your opportunity to weigh in on this, and then we'll see what y'all think. So it seems like many going for intermediate intensity chemo. Some opting for low intensity chemo, some for best supportive care. Tim, you can tell me, how we're doing on responses coming in.
Yeah, I think that's great. Thank you all for responding so quickly. So looks like everyone's settling on B. How did they do?
All right. Well, that is a great question, and that's a great place to start. So when I think about this patient here, I'm really wondering what to do myself. So I think B is a great place to start, and often I'm thinking of the 70-year-old as really that being my first option for them. But what I want to know is a couple more things before I make my decision. And so really this is where I bring the patient in, and we think a lot about shared decision making. And so as I mentioned, the high intensity paradigm versus the intermediate intensity paradigm, the efficacy of those outcomes is pretty similar. And so I'm going to want to think a lot about my patients and what matters most to them. So this is a nice framework that I've stolen from, it's the framework that Elwin gives in 2017. This has been adopted, but basically it's thinking about three different aspects of shared decision-making. And this is team talk. So let's work as a team to make a decision that suits you best. So we're coming beside patients, we're thinking about their choices, we're offering support to them, we're asking about their goals. And then we move into option talk. So then we think, well, here's kind of the high intensity framework. Here's the intermediate intensity framework, low intensity framework. Which of these do you think is most aligns with your goals? And then I can provide insight into my opinions at that point in time. So we're comparing options. And then really the third stage is to make some decisions. So decision talk. So then I say, okay, I've talked to you about high intensity, chemo versus intermediate intensity chemotherapy. What are you thinking? How does this align with your preferences? And then at that point in time, we want to understand their preferences, and we want to make preference-based decisions to make a decision. So I like this because it kind of moves us around in this, and then also says, man, we can go back and forth between those two things. The other thing that is really important for this patient is that I don't know her underlying frailty. So I know a lot about her leukemia, but I don't know really how frail or fit she is. And so here's the Geriatric Oncology Decision Framework, and this is from Clark Dumontier as the JCO publication 2021. Where they really suggest these three aspects for decision-making for our older patients. The first one is really determine aging-related vulnerability using a geriatric assessment. And this is the big point. There's been multiple studies that have come out demonstrating that age and cancer-specific data alone are often insufficient to guide treatment decision-making for patients. And so as an oncologist, if all I know is the age of the patient and their disease, I don't actually have enough information to decide on treatment because I don't know the vulnerability or the frailty of the patient. And so other studies have come out demonstrating that using kind of a geriatric assessment is much better than me eyeballing the ECOG-PS, which is the ECOG performance status. So patient comes in, I eyeball them, say, the performance status is about this, and using that as a surrogate for aging-related vulnerabilities. The GA is much better at doing that. And so what this does is, so once I am able to do the GA, then I consider benefits and harms of cancer treatment really in the context of vulnerability. And so I'm now tailoring my thought process more towards vulnerability. And then the last thing that we'll talk about in depth in a second is incorporating patient values and preferences for patients. And hot off the press, the American Society of Clinical Oncology has released some guidelines on how to do this practically. Really because many of us are time constrained in our clinics. We're finding it challenging to do a full GA, and how do we do that? And so the ASCO updated guidelines just a few months ago to talk about this specifically. And here are their guidelines. They say all patients age 65 and older should have a GA to guide management. And we'll talk about the practical GA that's available. They've also created videos on how to perform a GA and what to do with the results. So you can see them down here on the links to the YouTube videos down here. You can also get these just Googling ASCO guidelines on the practical assessment, and it'll come up as well. And then they suggest, number 2, impairment should have a GA identified management in the care plan. So really what we want to do is with the GA, we want to identify domains that are affected, and then decide on a management care plan to address those impairments through appropriate interventions, counseling, and referrals. And so here is kind of the quick practical geriatric assessment. And this includes both a patient reported side. So on the left side, you can see kind of the patient fills out this side of the assessment, and then a clinician fills out kind of the other side of the assessment as well. And this can be done fairly quickly in the office. And often you could send the practical geriatric assessment to patients beforehand to fill out, and then just complete the provider side in the office. And so this is really going to identify high priority domains where patients may be vulnerable. And so you may be wondering, well, what really are those domains? And ASCO has kind of highlighted these domains here. So function, falls, comorbidity, cognition, mood, nutrition, and then objective physical performance. And they suggest specific measures that have been shown in big clinical trials to be helpful and often actionable. And these are along here. Again, I won't go through these specifically, but I'll point you back to the ASCO guidelines and those videos. And I think the thing as clinicians, as we think through on this, is that we're really trying to get a place where we can do something in clinic that's easy to do and then leads to actionable steps. And so for me, I'm thinking about using these to inform treatment decision-making, about doing referrals, maybe physical therapy, addressing medication issues, etc. All right, so here comes our second audience poll question, and this is about the geriatric assessment for your patients. So what I want to know is, what is the current availability of GA for your patients? And so a couple options here. So GA performed by an oncology team, a GA routinely performed by a non-oncology team, GA occasionally performed, and then a geriatrician available for consultation if we need it, and then GA not currently routinely performed. And we'll see kind of what this looks like.
All right. We just want to say thank you to everyone for hopping on this next question. Of course, no right or wrong answer here, but it's interesting to see the different replies. So fairly evenly split between the routinely performed and not currently routinely performed. Is that a surprise, or is that in keeping with what you would expect?
Yeah, not a surprise. I'm actually, well, the surprise is that I'm grateful that the GA is being routinely performed by the oncology team. That is great news. Over the last probably decade or so, much data has come out on doing this, and so that is really, really good news that this is routinely performed in some settings. I think, for the other half of the folks, it's not really done, and that's kind of been the baseline for a long time. And so as ASCO and others are now moving forward and trying to get GAs into clinics to really identify vulnerabilities, hopefully we'll see those numbers really come down. All right, so I'll highlight, going back to patients with AML, that when we do GAs for patients, we find many impairments in many different domains. And so this is a collection of studies from Dr. Kleppman and Melissa Lowe and others looking at kind of across AML, kind of the different impairments that we find. And so some may ask, well, doing a geriatric assessment, how important is that really? But it's very important because we're going to see, domain impairments in many different domains. So physical function, very common. Polypharmacy, very common. Inaddressable. Comorbidities, certainly that's going to inform our treatment decision-making. And then many others, including social support, cognition, and nutritional status. And so we're seeing a lot of impairments in patients when we do a geriatric assessment that aren't going to come through on eyeballing. We aren't going to see the social support, cognition often. Maybe we'll get the comorbidities through the medical record, but a GA is going to identify these for us as well. All right, so let's go back to our patient. So again, 70-year-old woman who has intermediate risk AML. And here are kind of the, we did a GA for her, and here is the results. So she has some fatigue that's developed with her AML. Again, she has the diabetes and hypertension. Both are well controlled. She's independent on all her ADLs and IADLs, normal gait speed, cognitively intact, no depression. She certainly is anxious about her new diagnosis. And she's pretty active during the day, and she volunteers part-time at the library. So now let's go back to the question we asked earlier. So now we know she's a pretty fit 70-year-old woman who doesn't have a lot of comorbidities. And so now we're wondering about, should we do high-intensity chemotherapy, intermediate-intensity chemotherapy, or low-intensity chemotherapy for her? And let's see what you all think at this point in time. So I'm seeing some now takers for the higher intensity chemotherapy, or we didn't have that before. Most still on the intermediate intensity chemotherapy, and still a few on low intensity chemotherapy. I think that this is really good. I'm probably sitting in that space as well. And so often I'm asking now, well, how do I make that decision between? Often I'm thinking high-intensity chemotherapy. She's certainly a candidate for it. We think survival might be a little bit longer, though we don't know. Would she be a transplant candidate? High risk, high reward. How do we determine that? And so really this is the point where I start thinking about, man, I need to have a pretty important conversation with her about what matters most to her. And so about kind of what she understands about prognosis with the disease. And so here are a couple studies I wanted to highlight, and I said we would come back to preferences and prognosis later. And so this is what we're going to do. Here is a sobering slide for me as an oncologist. So I'll orient you to this slide. So the question really is, what do AML patients understand about a prognosis? we think that understanding of prognosis is really important to inform treatment decision-making. And patients think the same thing. About 95% of patients reported wanting to have a conversation about their prognosis. And so when you look on kind of the left side, so this is all patients, what do they understand about their prognosis? So this is patients versus oncologists, and how likely are they to be cured of their cancer or their AML. So when you look at this bar graph on the left, that far left patient bar graph, you see 90% of patients think that it is somewhat likely or very likely that they're going to be cured of their leukemia. Whereas for oncologists, only about 26% of oncologists feel like for most patients it's somewhat likely that they're going to be cured of their leukemia. And so what you can see is a huge disparity in the prognostic understanding of patients, who almost all of them feel like they are going to be cured, and oncologists who recognize that cure is often not possible for patients with leukemia. Those disparities are worse in patients receiving lower intensity chemotherapy. Again, I said at the beginning, this is really geared toward quality of life alone, but still 82% of patients feeling like they're going to be cured with this in general. So overall, we have a ways to go. So going back to our patient, thinking about our patient and saying, man, what are we going to choose? Our first thing is really to help them understand their treatment options and their prognosis as well. Again, sobering that about 31% patients report never or rarely having a conversation about their prognosis. All right, so after I talk to the patient, give them options, we're walking through shared decision-making, I'm talking to them about outcomes in AML. Next thing I want to do is really talk about what's most important to them. And this is a study of about 800 plus patients with AML that asked them really what were the things that those worries that drove your treatment decision making. And so most patients would say, man, possibility of dying drives my decision making, long-term side effects drives my decision making, other things that are important, being a burden to others, returning to daily activities. Here's that spending time in the hospital. So I think about that a lot, of inpatient versus outpatient chemotherapy. Side effects, financial costs, et cetera, much less important to patients than kind of the top items there on the list. And what this study showed is that the worries are really varied and heterogeneous, and survival often the most important, but not always the most important to patients. And here's another study looking specifically at that question of how heterogeneous are the preferences of patients with AML. What you can see, and I won't walk through the details of this study, but basically you see the blue group and the orange group. The blue group tends to balance treatment effect and side effects, whereas the orange group tends to highly value complete remission. And so these are the patients that we see that say, Doc, I don't care about the side effects. I don't care what I need to go through. All I want to do is live longer. Give me my best shot at living longer. And so patients vary widely on their preference for aggressiveness of chemotherapy. All right, and so I said that we would talk about some tools to help us in this space as well. One of the tools that we use a lot in research are stated preference methods. These are basically standard methods to have patients pick between one choice and the other to help inform treatment decision-making. So on the right side, here's a discrete choice experiment. It's a multi-profile discrete choice experiment. We won't really go into the details other than to say that there are certainly ways that we are starting to develop on the research side and moving into clinic to help inform this discussion of patient preferences. And so my team, my research team develops a lot of discrete choice experiments. Best worst scaling is another way to do it. There are other research groups. So here's a clinical trial for patients with prostate cancer using a discrete choice experiment that's adaptive to help inform this question. So we're sitting with a 70-year-old with AML. She's eligible for high-intensity chemo. Maybe we're thinking intermediate-intensity chemo. How do we know what's most important to her? Other groups have developed other tools. So this is a pretty simple one called the outcome prioritization tool. Very easy. So 4 outcomes here: life extension, preserving independence, reducing pain, reducing other symptoms on here. Patients pick between those. A collaborator of mine, Melissa Lowe, and LeCastro have developed communication tools which combine the geriatric assessment and best score scaling to elicit patient values. And so as we think about this and going back to our patient, now we're thinking, man, this patient, I talked to her about high intensity, I talked to her about intermediate intensity, and really she's interested in cancer-directed treatment, but she prefers to stay out of the hospital. She doesn't want to stay in the hospital for a while. She prioritizes quality of life and location of treatment. And so going back to kind of thinking about this, framework that I put forward for treatment decision-making for AML, we have kind of the clinical features and the potential outcomes. And now we're really thinking about, man, where do patient preferences fall along this line? And so the high risk, high reward, or the fewer side effects. And so we're thinking about kind of these different options for this patient. All right, so one last time here. So this patient really prefers quality of life, wants to stay out of the hospital, but really also wants disease-directed therapy and wants to have good outcomes for that as well. So now, where are we thinking for this patient, and where are we at kind of on this spectrum for this patient? Yeah, and this is great. So I see we've lost that, that group of patients thinking about high intensity chemotherapy. I would have been thinking long and hard about that before the conversation with the patient, about her saying, man, I want to prioritize staying out of the hospital, want to spend more time at home. In my book, depending on kind of the mutations for the patient, azacitidine plus venetoclax is going to have significantly higher remission rates. And so I'm really only thinking about that lowest intensity chemotherapy for patients who are significantly more frail than this patient here. And so I'm often thinking about combination chemotherapy, azacitidine plus venetoclax. Most of you, I think, are right on board with me. The lower intensity therapy, as I said, lower remission rates, probably not what I would choose for her in this case. All right, so let's shift gears. And this is, I know I'm running out of time. I just have a few slides. We spent most of our time on AML, and I'm just going to highlight a few changes and updates for ALL. Also, very devastating disease. Treatment outcomes are poor. This is leukemia from the lymphoblastic cells, and we see kind of 2 peaks in kind of the population. So many patients with patients with AML are young, so ages 1 to about 10 or so, and then we see it in the older adults as well. And I'll just highlight some of the new approvals for ALL. So inotuzumab is a new drug. It's a CD22 monoclonal antibody that's actually attached to a payload. And so it has a targeted therapy that's attached to a chemotherapy payload. So I think of it really as a stealth missile. And often I'm thinking about giving this to patients who have relapsed disease. Some of the benefits: improve survival versus salvage chemotherapy, though it does come with some liver damage as well. The second thing, new development, is blinatumomab. This is a bispecific antibody. And so what that means is it takes CD19 cells, so it attaches to CD19 cells and brings along the T cell. And we use this a lot for patients with relapsed ALL or in ALL that has a little bit of disease left. So these are the those patients to try to clear out that disease. And the last thing we'll talk about here is really CAR T cells. And so certainly you could do months of training on CAR T cells, but I'll just bring it up here. So CAR T cells are a process where we take T cells from the patient, we bring that out of the patients, and then we train them up like ninja fighters to send them back into the patient to attack the disease. Most of these for ALL are CD19 directed CARs, and we now have 2 approved CAR T constructs for patients with ALL. Younger patients can get Tisa-cel, older and all the other patients can get Brexa-cel. There's much more to say about this. We're thinking about using this really in the relapse setting for our patients. Many patients were also thinking about this in the setting of clinical trials and trying to get it earlier on in therapy. Pretty well tolerated. I often, think about it as a transplant light, and that you get some chemotherapy up front, you get the CAR T cells, and then you really are harnessing the immune system of the patient with these ninja fighting cells to attack the disease. All right, last point here. Similar to in AML, with the addition of blinatumomab, with the addition of novel TKIs, and I didn't hit on them very much as well, but for patients with Ph-positive ALL, we now have many different options to think about. And often I think for our older patients, we're thinking in a few buckets. The high intensity bucket where we're using cytotoxic chemotherapy plus a tyrosine kinase inhibitor, that's the TKI. Highest side effects, but high remission rates. And then we really think about a lower relapse rate of using the high intensity therapy. Intermediate intensity, these are for our older patients. I think about using upfront blinatumomab. This is the FOA paper NEJM using blinatumomab plus a TKI. High response rates in ALL, we're getting 90+% response rates for patients. Less side effects in this setting, but we question kind of the higher relapse rate. And then lower intensity chemotherapy. These are our frailer patients. Again, GA can drive a lot of this. We're using steroids, we're using TKIs, plus minus vincristine, and then low side effects, still a high CR rate, but really we're balancing this with kind of the higher relapse rate in this setting. So all that to say, across leukemia, many new developments, kind of this transition, this paradigm shift from treating right away with higher intensity therapy, now moving into patient-centered care, personalized medicine, really understanding what is most important to patients. All right, and with that, I will, again, thank my study team, the funding. I showed some of my studies today, so I want to thank them. And then I think we have a few minutes for questions. Tim, you can kind of direct that. You can tell me if there's anything else you want me to say for that perspective.
Absolutely. Dr. Richardson, thank you so much. This has been great. We now have an opportunity for everyone out in the audience to go ahead and start sharing your questions in Poll Everywhere with Dr. Richardson. While we're waiting for a few of those to come in, let me ask, how do the patient's expectations about side effects line up with their experiences? So, I can see in this whole decision-making process, a patient may say, gosh, that sounds like I can manage that, and then finds out then it's much worse than they expected, or conversely, maybe it's not as bad as what was expected.
Yeah, that is really a tremendous question, and it kind of hits on kind of across the paradigm. Some patients will come in and they'll think, oh no, not the side effects. I've seen the movies on, chemotherapy, and, it's always terrible. I don't want to do it. And we're kind of in the seat of saying, here are other patients who have tolerated it pretty well. And so sometimes we're kind of advising them, saying that it's pretty tolerable. And then other times patients will be thinking, oh, I'll get through it, no problem. Give me the highest intensity chemotherapy. Maybe there are older patients with frailty that's identified on GA. And we're really helping them, in that shared decision-making process to understand kind of the trade-offs that they make for those side effects. And so expectations are really important, personal experiences. We didn't talk about transplant today, but that comes kind of with a whole nother bucket of expectations and experiences as well for patients.
Yeah, great. Thank you so much. We do have a question came in. What do you do when a patient doesn't remember having these discussions and expresses dissatisfaction with the decision-making process? Of course, now they have access to their chart notes.
Oh man, I love this question because it allows me to kind of get off my soapbox a little bit. I give this presentation or some of the slides to other leukemia docs, and all of them will say, we talked to the patient. We told them about kind of all of this. We walked through everything. And probably what's happening is that they are actually doing that. And the distress of the experience, once patients get into, I have cancer, I have leukemia, they have a cognitive dissonance that happens where they can't remember anything. They don't remember having these discussions. They may be dissatisfied, et cetera. And now they have access to their chart notes. I think that, so a couple of things on the research side and then the clinical side. So I think that on the research side, I think moving some of the understanding on the patient side outside of that distress of the clinical counter can be really helpful. So can we, talk to patients up front, engage them beforehand, or spread out the clinical encounter from one where we see them, talk about what's going on, introduce things, and then have a second encounter to make decisions. That kind of expansion of the treatment decision-making process allows for some, kind of the reduction of the distress and helps patients do that. The access to the chart notes, I think that is really good. I'm thankful for that. Hopefully patients can see, their notes. But, I try to be as transparent with patients because I think that having them know their prognosis is helpful. Some patients will say, man, I don't want to know, about what prognosis is. Don't tell me, just, walk me through this. And so then you have to be a little bit careful with what you write in their chart.
Great. Thank you so much. As you're talking about this, I'm reminded of what I believe Dr. Nakamura said about cognitive impairment starting at the moment of diagnosis, what we might have previously called chemo brain, thinking about it when chemo starts. And no, he speaks to it being at the time of diagnosis.
Yeah, that's exactly right.
Okay, well, this is great. Maybe one more. I'm looking to see if any other members of our audience have questions. I thought it was interesting how on the looking at the importance placed on the communication with the physician, that was very low on that chart that you had shared, and yet the dissonance in terms of those expectations around prognosis between the physicians and the patients. What do you see opportunities to correct that, and what might be put in place to bring the different viewpoints more in line?
Yeah, I mean, that's really good. And I think so. Our team is working on some tools, as I said, to get kind of patient values and preferences up front. What we see is that when you talk about patient preferences and values, you talk about what matters most to patients. What they begin to see is that this isn't about choosing a chemotherapy. This is really about going on a journey together, understanding what matters most, and then really saying, hey, I'm beside you and we have these options. Let's make a decision together where we can do this. And when we're able to do that and come beside patients, we can increase satisfaction for patients. And so, I think that there's also the reality that satisfaction comes with outcomes. And so for patients that have bad outcomes, they might be dissatisfied regardless. They always have decisional regret as well.
Sure. Thank you so much. I really appreciate having you here today. This has been fascinating.
That was a lot of fun. Thanks so much.
Absolutely. Just a few closing remarks. I want to, of course, thank the people of North Carolina for their generous support of the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. I want to thank the team here at the UNC Lineberger Cancer Network, Benny Obore, John Powell, Oliver Marth, Andrew Dodson, Patrick Muscarella, Lindsay Reich, and Barbara Walsh. They all work hard on each one of these lectures. Thank you.